Observation of your patient. Assessing an IV system. All patients with IV fluid therapy, whether it's a peripheral or a central, are at risk for developing IV-related complications. The assessment of an IV system, including the IV site, tubing, rate, and solution, often depends on what is being infused, the patient's age and medical condition, type of IV therapy, whether it's a PIV or a CVC, and agency policy. So there's a checklist typically used to assessing an IV system. So all IV systems must be assessed every 1 to 2 hours or more frequently if required. An IV system should be assessed at the beginning of a shift and at the end of the shift if the electronic infusion device alarms or sounds, or if a patient complains of pain, tenderness, or discomfort at the IV insertion site. Review the patient's chart to determine insertion date and type of solution ordered. A peripherally inserted catheter is usually replaced every 72 to 96 hours, depending on agency policy. If the peripheral catheter, or CVC, is not in use or is being used intermittently, flushing is required to keep the site patent or open. Refer to agency policy for flushing guidelines. A not-in-use PIV is generally flushed every 12 hours with 3 to 5 mL of normal saline. Review the in and out sheet to determine expected amount in the IV solution bag. Patients with cardiac or renal disease, as well as pediatric patients, are at high risk for IV-related complications. Elderly patients often have fragile veins and may require closer monitoring. So there's some steps here. So you want to perform hand hygiene. This step reduces the transmission of microorganisms. You want to introduce yourself and explain the purpose of the assessment. This builds trust with the patient. Confirm the patient's ID and 2 patient identifiers. This is to ensure, of course, you have the correct patient. Then you're going to apply non-sterile gloves. Now, this is optional. If you're just looking at the site, you may not need to put gloves on. Assess the IV insertion site and transparent dressing on the IV site. So you're going to check this for signs and symptoms of infection, such as phlebitis or infiltration. You're going to check for any fluid leaking, any swelling, make sure there's no pain. You're going to make sure the patient is feeling okay with their site. You're going to inspect their arm for streaking or what we call venous cords. And you're going to assess the skin temperature. This is a good indication of infiltration or extravasation. You're going to assess the IV tubing for kinks or bends. You're going to check the rate of the infusion of the primary and secondary IV tubing if being used. You're going to verify the rates that the physician ordered, or the medication administration is what's per the MAR. You're going to also assess the type of solution and label it make sure it's labeled on the bag. You're going to check the volume of the solution in the bag. You're going to assist the patient into a comfortable position, place call bell in reach, and then put up the side rails per your agency policy. You're going to then perform hand hygiene again, and then you're going to document what you've learned. So some common IV complications. There are 4 common complications that occur with peripheral IV: dislodgement, infiltration, occlusion, and phlebitis. With all of these complications, harmful forces on the IV line are major precipitating factor. The 4 complications related to mechanical forces are described in the following slides. Dislodgement. Dislodgement occurs when forces across the IV line are stronger than the adhesives and securement devices, the ability to hold the IV line, making it a purely mechanical complication. Clinical studies show that IV dislodgement is a common complication, occurring 11% time on average. Dislodgement can occur either on purpose or accident, with some of the most common reasons being patients transfer from one bed to the other, patients with cognitive issues, unknowingly pulling out their IV, and IV lines getting caught underneath hospital bed rails. So here we have two pictures. On the left is a dislodgement from a confused patient, and on the right is one that just gets caught up in the bed sheets. Then we have infiltration. Infiltration is the most common complication for peripheral IVs, occurring 24% of the time on average. Infiltration occurs from erosion or penetration of the catheter into or through the vein wall. It results in the infusion of medicine into the surrounding soft tissues and can be seen in the image to the right. And actually, the way this is being recorded, it's ended up below us. The erosion of the vein can be caused by the forces on the IV line, causing the IV catheter to move back and forth in the vein, injury due to the caustic medicine being infused, or needle injury to the vein during insertion. Securing and preventing harmful forces from moving the catheter back and forth are critical in preventing infiltration. And here's a picture of an infiltration. And there is this is an actual YouTube video. You should be able to click this in the downloadable file to actually have that play. Phlebitis is a vein irritation as seen in the picture below, and again, it's on the next slide, the way this is recorded. This occurs 15% of the time on average in peripheral IVs and is the second most common mechanical complication. There are 3 different types of phlebitis: mechanical, chemical, and infectious, though any combination of the 3 can occur. Mechanical phlebitis is caused by the traumatic movement of the IV catheter against the vessel wall, and chemical phlebitis is caused by a reaction of the vein to the medication that is being infused. Stabilization devices have shown improvements in phlebitis rates in some studies. Preventing harmful forces from reaching the catheter is important when trying to eliminate mechanical phlebitis. So this is what phlebitis looks like. It gets really red and sometimes lasts forever. And again, another YouTube video that you'll be able to play in the downloaded PowerPoint. Occlusion. Occlusions occur when the opening of an IV catheter becomes blocked due to buildup of biological material. It's usually a fibrin sheath that forms. And this is responsible for 19% of all IV catheter failures. If the IV catheter is pulled back and forth inside the vein, this can cause the catheter to scrape and gather material from the inner wall of the vein at the tip of the opening of the catheter. This reducing the movement of the catheter in the vein can help prevent the buildup of the material on the catheter that leads to occlusion.